This chart tracks metrics since 1990. The first line shows a massive surge in antidepressant prescriptions. The second shows depression rates remaining flat. We're maintaining a population on medication for a condition it hasn't reduced, a statistical failure. In July 2022, the journal Molecular Psychiatry published a systematic umbrella review by Joanna Moncrief and her colleagues, synthesizing decades of psychiatric evidence. The researchers concluded that the main areas of serotonin research provide no consistent evidence of an association between serotonin and depression. The foundational biological idiom of modern psychiatry, the serotonin hypothesis, lacked clinical support. An entire generation of patients was treated for a chemical deficit that did not exist. Existential suffering is a highly conserved evolutionary alarm signal. It indicates that a person's relationship to their environment, their purpose, and their community has collapsed. Treating a structural alarm signal with a pharmacological mute button guarantees long-term failure. To actually stop the alarm, we have to decode what the signal is trying to tell us. This flowchart illustrates the somatization myth. Medical institutions routinely translate psychosocial distress into a biological pathology, building massive institutional treatments around that translation. For 2,000 years, medical texts attributed female distress to a wandering womb. By the late 19th century, Jean-Martin Charcot built an institutional spectacle around this, diagnosing women with hysteria and exhibiting their convulsions to audiences in Paris. As the industrial era accelerated, doctors diagnosed the resulting despair as the disease neurasthenia, claiming modern civilization's fast pace physically depleted the nerves. Even ancient Greek medicine blamed severe low mood on a biological excess of black bile. Yet the treatments Hippocrates actually prescribed were overwhelmingly psychosocial: dietary modification, vigorous exercise, and social engagement. The Industrial Revolution systematically dismantled the environmental structures that historically held human suffering. It fragmented labor, severed ties to the natural landscape, and dissolved extended kinship networks, creating a pervasive crisis of alienation. Whenever a society destroys the architecture of human connection, its medical institutions inevitably invent a biological disease to pathologize the resulting despair. Randolph Ness's framework of evolutionary psychiatry reframes the nature of low mood entirely. In this model, severe low mood functions like physical pain. It's an evolved biological adaptation signaling that current life strategies are actively failing. Psychologist Martin Seligman demonstrated the mechanics of this paralysis through his behavioral model of learned helplessness. Learned helplessness occurs when an organism learns it has zero control over aversive outcomes in its environment. Once that lack of agency is internalized, the organism ceases all effort, even when an escape route later becomes available. Evolutionary biologists Paul Andrews and J. Anderson Thompson connect this helplessness to the analytical rumination hypothesis. Depression forces the brain into a hyper-focused physiological loop, effectively shutting down outward behavior so the mind can analyze complex, seemingly unsolvable life problems. Depression functions as an analytical alarm system triggered by a loss of control. The only mechanistic cure is the structural restoration of personal agency. This 3D wireframe models the default mode network. These connected brain regions activate during self-referential mind-wandering. During depressive rumination, the DMN becomes pathologically hyperactive, trapping the brain in a rigid, inward-facing loop of negative evaluation. Neuroscientists Carhart Harris and Friston developed the Rebus model to map how we interrupt this frozen network. Mechanistically, psychedelics heat up the brain, melting rigid DMN pathways and allowing an explosion of novel cognitive configurations. The psychedelic pharmacology is merely a catalyst. The strongest predictor of clinical recovery is the mystical or peak experience, the ego dissolution and meaning-making that occurs within a highly structured communal ritual. Breaking the cycle of despair requires physically disrupting the DMN's self-referential loop. That neurological reset is achieved through intense, structured experiential shifts, not by taking a daily pill. Clinical researchers at Duke University tested this concept of agency-based treatment in the SMILE trials. pitting aerobic exercise directly against the SSRI sertraline. This bar chart displays 16-week results. Intense physical activity reduced depressive symptoms equivalently to prescription medication. At the 10-month follow-up, the medication group's relapse rate spikes to 38%, while the exercise-only group stays at just 8%. Lead researcher James Blumenthal concluded that exercise succeeds long-term because it requires the patient to physically act. It restores their belief in their own self-efficacy, actively reversing the biology of learned helplessness. Finland's open dialogue approach applies this same logic to entire relational webs, treating first-episode psychosis without immediately defaulting to heavy neuroleptic drugs. When Kouropoudis Hospital responded to mental health crises by treating the patient's entire social network rather than medicating an isolated individual, their 5-year data showed an 83% return to work rate, with 77% of patients remaining symptom-free. Contemporary clinical evidence proves that treating the relational web and restoring personal agency yields superior, durable outcomes compared to treating an isolated brain. Pre-modern cultures empirically stumbled upon and perfected these exact neurobiological interventions centuries before modern fMRI machines existed. In the 6th century, the rule of Saint Benedict established the horarium, a strict daily schedule dividing the monastic day into periods of communal prayer, manual labor, and shared meals. The medieval horarium functioned as a highly sophisticated psychological technology. It enforced strict circadian entrainment and demanded rigorous behavioral activation to combat the paralyzing despair the monks called acedia. The medieval pilgrimage routes across Europe functioned the same way, walking hundreds of miles, combining intense physical exertion, a clear sense of purpose, deep community bonding, and immersion in natural landscapes. This was a multimodal intervention that effectively downregulated the default mode network. We trace this instinct to the deepest bioarchaeology of care. 36,000 years ago, humans descended into caves to impose symbolic order on their world. The fossil record shows Neanderthals and early hominins provisioning incapacitated members of their groups for years. These pre-modern rituals and prehistoric care networks functioned as multimodal psychological systems, engineered over millennia to maintain human homeostasis. This matrix plots 8 restorative elements against human history. Across 2 million years, cultures facing existential collapse consistently reached for the exact same tools. There is a perfect alignment between ancient Athenian philosophy, indigenous healing circles, monastic traditions, and modern randomized controlled trials. These 8 elements constitute the primary medicine for human flourishing. They are the bedrock of recovery. The modern institutional apparatus abandoned this wisdom. It isolated the patient, monetized a false somatic theory, and pathologized the signal meant to guide us back to connection. Existential suffering is a relational, purposive, and structural deficit. The hole it digs cannot be filled by a chemical. Human beings are not isolated biochemical machines. We are profoundly relational creatures, and the bedrock treatments we need to heal have been standing, waiting to be rediscovered for 2 million years.